There's actually almost no evidence to support the kind of classifications which you find in diagnostic manuals.
So if you score 22, you're depressed, and if you score 21, you're not depressed. Life is not like that.
These days, however, the people who define what gets treated aren't patients who are ill, are doctors that look for lesion. It's the marketing departments of pharmaceutical companies.
These days, from depression to bipolar disorder, we think psychiatric diagnoses are real, but there are those who argue that categories of mental illness have little basis in nature. So is it time to abandon psychiatry and its classifications? Would this usher in a new era of effective healthcare, or would it actually cause widespread harm? Well, joining me to discuss all of this and our attitude towards mental illness and its diagnosis are Richard Bentall, psychologist and author of Madness Explained and Doctoring the Mind. He's also the Professor of Psychology at the University of Liverpool. Dinesh Bhugra, President of the World Psychiatric Association. President-elect, I'm sorry, and Professor of Mental Health at the Institute of Psychiatry at King's College London. He specialises in cross-cultural psychiatry. David Healy, who tells me he's not a radical psychiatrist, as suggested in the brochure. He is, though, a professor in psychological medicine, and he's known for criticising the lack of neutrality regarding psychotropic drugs. Is that right?
That's what it says in the brief.
That's what it says on the brief, must be. And his books include The Antidepressant Era and Pharmageddon.
Okay, so my problem with psychiatric classification is that it is about whether it achieves the purposes for which it's designed. So whether, for example, psychiatric classification allows us to identify the causes of psychiatric problems by identifying groups of people who have the same cause to their problems, whether, for example, it allows us to decide what kind of treatments people should do, whether it's a good predictor of treatment, where it allows us to make other types of decisions in the clinical domain. And in all those respects, psychiatric classifications as they exist today just don't work. There's actually almost no evidence to support the kind of classifications which you find in diagnostic manuals such as the American Psychiatric Association's Diagnostic and Statistical Manual, the DSM, which you've probably heard of. So what can we do about that? Well, one possibility is that if we were really smart, we could maybe come up with a better system of psychiatric classification, but a lot of people have been trying to do that and not succeed. My view is that we need to focus on the individual types of problems and experiences which people have. So for example, it makes sense to ask, why are people hearing voices? That's a sensible question. And how can you help people who hear voices? It doesn't make sense to ask, why do people have schizophrenia, and what can we do to help people who have schizophrenia? Because schizophrenia is a ragbag category which has no meaning in terms of, it doesn't map onto reality in any way.
Why do we need classification? I think we need classification because that's human nature. We like to classify things by color, by size, by any number of things. And yes, of course, classification in psychiatry is not perfect. We have to bear in mind that psychiatry is where medicine was 150 years ago, so we still have about 150 years to go before we can be at par with medicine. 150 years ago, if you were coughing and you had temperature and doctors decided you had tuberculosis, you were sent off to an asylum. And for whatever reason, diet, climate got you better or not. Subsequently, it was discovered that there was a bacillus which caused it. You created antibiotics and then vaccinations. Psychiatry is at that stage where we need to be thinking about, there is a disjunct between what patients want and what psychiatrists do. Patients are interested in illness, psychiatrists are interested in disease. And I think more about that when we have further discussion. So I want you to sort of bear that in mind. In terms of classification, I think what we need to bear in mind is that we ought to be focusing on illnesses rather than diseases. And DSM is a wonderful system for America, and long may it stay there. I have no idea why the rest of the world chooses to follow DSM. So my plea is that, I encourage my American friends and colleagues, can they just hang on to it there and not send it anywhere else? Thank you.
Richard will talk to you roughly about we're all minds. The important thing about you guys is your mind. Dinesh thinks it's your body. I think the important thing in mental health care is power. Forget mind, forget body. I don't know if we're all mind or all body or a mix of the two. But I think the key thing when you engage the mental health system is power. Dinesh has talked about illness and disease. Well, actually, the issues we're going to treat began as people complaining, illnesses. Once we began to learn more about what caused the complaints, we began to look at lesions. Is there a biological change that's caused these particular kind of problems, symptoms? These days, however, the people who define what gets treated aren't patients who are ill, are doctors that look for lesion. It's the marketing departments of pharmaceutical companies. In the 1980s, when you were tense, you were anxious. You were a case of Valium. Exactly the same kind of complaints were defined during the 1990s as depression. You were a case of Prozac. In the noughties, you became a bipolar disorder. It's got nothing to do with what Richard talks about. It's got nothing to do with what Dinesh talks about. These days, it's all about the pharmaceutical industry. The illnesses are real. The categories are extraordinarily important. If you want me to differentiate, let's say you've got a husband or a wife who's bereaved and you want to make sure that I don't put them on antidepressants for that, then it's extraordinarily important that we have a category of depression. If you're pregnant and you don't want me to treat you for being depressed because you've got poor sleep, poor appetite and things like that with an antidepressant, it's extraordinarily important that we have a category. The problem these days, however, is that all of this language has got lifted up by the pharmaceutical industry and it's been deployed to their purposes.
We have these psychiatric classifications. Richard Bentall, how are they created? How are they discovered? How do we arrive at them in the first place?
Most of the clinical concepts which are used in psychiatry today and by clinical psychologists as well, of course, were developed in the 19th century by psychiatrists who observed their patients and tried to identify patients who they thought suffered from different diseases. They did this largely by trying to find groups of symptoms which they thought went together and which had a common outcome. That was the idea. And there's a particular psychiatrist called Emil Kraepelin who came up with the concept of dementia precox, which we now call schizophrenia, which is the sort of template for this approach, really, I suppose. Kraepelin was probably the most influential psychiatrist ever, probably more influential than Freud, for example, even though Freud is a household name. So that was how they took that, how they tried to do it. And they tried to do it by clinical observation in the same way which they did in general medicine. The problem is that once these diagnoses were created, they sort of took on a life of their own. So if you take the concept of schizophrenia, for example, that people have come to accept, because it's natural to do this, that there's a kind of essence behind schizophrenia. So that if you have a diagnosis of schizophrenia, that means that schizophrenia is the cause of your problem. So you hear voices. Why do you hear voices? It's because you've got schizophrenia. But once you take away the symptom, once you look at all the symptoms, there's no schizophrenia underneath the symptoms. Nobody's ever found something in the brain which is schizophrenia. It's
actually obscuring the reality of the illness. The label is misleading. It's a blunt instrument.
It's highly misleading in that particular case, because what it does is it lumps together a lot of problems which actually in reality, when we do statistical research to look at how these things go together, they just don't go together in that way. It isn't true that you've got a cluster of symptoms which correspond to this diagnosis of schizophrenia. So you can have two people have a diagnosis of schizophrenia, have no symptoms in common. So why is it we would think that they have the same disease? So,
Dinesh Bhugra, why are we sticking with these classifications if they can be misleading and actually obscure our understanding of a condition?
I think there's sort of several strands. Richard is right, but he's also wrong. He's right in the sense that no two patients are alike. When I'm sitting in the clinic, two people who are hearing voices come to me. The contents are very different. Their responses are very different. Responses of people who are looking after them are very, very different. And I think part of the tragedy of medicine has been that we've gone down a very kind of tick box exercise And the current system in the National Health Service does not allow us to veer away from that. So the challenge for all of us, and I think I did try to work on and be doing a piece of work on behalf of the Mental Health Foundation, looking at psychiatry's contract with society. What is it that society expects from us, and what do we and can we offer that in return or not? So it is, I mean, in the end, in clinical terms, it's the patient at the core of what we do. They are surrounded by, family and the carers and their employers and so on and so forth, surrounded by larger society and culture. And somewhere along the line, I think we've forgotten the rest of what's going on around the patient.
But, I mean, you were quite critical of the American system, the DSM. Does that suggest then the classification system has to vary from country to country because society and cultures vary?
Yes.
But that isn't the case.
That isn't the case. I mean, I think part of the problem, I mean, as a sort of cross-cultural psychiatrist, I always see that if you're using instruments which have been developed in one culture blindly onto another, you get lots of false positives. And you also get lots of false negatives, and you miss individuals who need help, because part of the challenge for clinicians is that it's what the patient is saying, but also what the patient is not saying. If we rely on tick box or checklists, it becomes a kind of threshold. So if you score 22, you're depressed, and if you score 21, you're not depressed. Life is not like that. What is happening to me, and how is it affecting my function, my relationships, my job, is much more important.
Do you think then, if it is as individualized as Dinesh describes, can classifications help? Can they at least lead us down a path at which then each particular practitioner has to make his or her own judgment?
Let me step back. I think the categories are real, the illnesses are real. Richard's led you down the garden path. He's talked about Kreplin, and there's no such thing as schizophrenia. Well, Kreplin isolated dementia praecox and dementia paralytica, and they look awfully similar. Now, as it turns out, we have found the underpinning for dementia paralytica. We know exactly what it is. Dinesh said we're not doing very well. We're way behind the rest of medicine. In fact, psychiatry has been way ahead of most of medicine. It was the first to have specialist hospitals, the first to have specialist journals, the first to isolate and cure major illnesses like dementia paralytica. So the broad thrust is actually correct. There's a whole range of other illnesses that it's cleared up. There was a ferocious condition called catatonia, which if you went into the mental hospitals 50 years ago, you'd have seen people lying in the same posture in their feces and urine for months on end, okay? It's gone. You guys just don't see it, okay? So we have made huge progress. The problem is we're dealing with the trickiest area of medicine. The brain is incredibly complex, trying to get to the bottom of what the illness is. I'm sure in due course schizophrenia is going to turn out to be a bunch of things, but to have this broad grouping of chronic psychoses makes sense. The problem we've got isn't the hardcore of illnesses which mental health should be dealing with. The problem is how the pharmaceutical industry has picked all of that up and has reached out into the community. During the 1960s is when this began, when people like Dinesh and me were institutionalized in mental hospitals. We were no threat to the rest of you. But once they deinstitutionalized psychiatrists out into the community, we began picking up people out there who were depressed and things like that, and began putting them on treatments which aren't going to help you, which are helpful for people who are in the hospitals, but aren't helpful for most people who get put on them. That's where the problem lies. The categorization issue is a red herring.
Is psychiatry distorted, essentially, either by big pharma or these misleading classifications?
I think that's a very simplistic view to blame everything on pharma. My view is that, ideal scenario, if, I keep going back to the patient who's sitting in front of me, what would I say to him or her? Sometimes it would be a mixture of medication and supportive work. Sometimes it would be family therapy. Sometimes it would be couple work. Sometimes it would be a whole host of other things. So it's not either or. And I think the issue for us as clinicians, and if we're looking at the broader issue, in Japan, for example, they've stopped using the term schizophrenia because they think that schizophrenia is stigmatizing, and therefore they've come up with something called disorders of disintegration disorder. Now, I don't know what disintegration means. You know, disintegration for me is very, very different from, you know, disintegration for somebody else, because, you know, and I always kind of, to my trainees, tell them that, you know, if a professor of neurology presents to the clinic hearing voices, that's going to be very, very different from a kind of manual laborer. Their experiences are very different. Their life stories are very different. Their kind of connections are very different. As simple as that.
Okay, so it seems to me that there are two problems of psychiatric diagnosis, which perhaps I haven't actually made as clear as perhaps I might have done. One is that, so we want to find out the causes of psychiatric disorders in people like myself who do research. And if you group together a lot of people who have, under this one label, schizophrenia, say, and it applies to other labels as well, and if you then try and identify common factors which are in their, you know, in their life, which might be responsible for their difficulties, such as genes or something like that, you're not going to be able to do that if the classification system has no basis in reality. So if you get a bunch of people who have a widely different problems, you call them patients suffering from schizophrenia, you compare them with other people, what's going to happen is you're going to get a mess. And that's exactly what we have got out of schizophrenia research. So I would say that the psychiatric diagnoses, as they're used at the moment, have been highly misleading. They've impeded the progress of science. They've impeded our understanding of why people have psychiatry.
Asking for an updated, more detailed version?
Yeah, I said at the beginning, I'm not against classification in principle. I don't think you can have any scientific endeavor without some degree of classification. But the second point which I want to make is this, which is the other side of this problem is a tendency to see the disorder as the diagnosis as the cause. So we go, the patient hears voices because they have schizophrenia. The problem is located inside the patient. We ask what is wrong with the patient. What that stops us from doing is asking what has happened to the patient. What is it in the patient's life which has led to these kind of experiences? And actually psychiatry has been, particularly over the last 30 or 40 years, has been very bad at looking at the social determinants of the life stories of the patients who psychiatrists see as a general. So the most common complaint that patients make, in my experience, is that nobody was interested in my story. They go into hospital, they get a diagnosis, they're given some drugs, and they're expected to get on with their lives.
Are we, in the way in which mental health is dealt with, in the way in which we treat patients, whether we talk to them or don't talk to them, is that moving forward the treatment of patients, or actually is the entire system flawed?
Richard has invoked DSM and things like that, and Dinesh has too. But in fact, most psychiatrists in the UK, in case you don't know it, work with about 8 or 10 illnesses. That's it. Okay, we do not have all of the illnesses that are in all these manuals you hear about. They're in the States, they play very little part in our lives. But what does play a part in our lives and in your lives is, for instance, there's things like autistic spectrum disorder, which you'll all have heard about. Is it a real illness or not? Well, there's an issue for people like Richard, a sort of an academic issue about how many angels fit on the head of a pin. How do we split all these things up? What way should we try and define the category? In fact, the issue that's of much greater importance to you is not whether Richard and I can go into a room and come up with the criteria for an illness, but are the fact that the criteria these days are up on the internet. And I will even have, and this has happened, a politician or a person from the media who'll be hugely socially skilled, who'll go in and read these criteria and tick the boxes and come in and ask me seriously, do I have autistic spectrum disorder? I think I have. I meet the criteria for this illness. And they want an answer. Because the criteria there, the illness is real, and they want an answer for that. They'll have been to a clinical psychologist, a few of them beforehand, who agree, because you meet the criteria, you have autistic spectrum disorder. And this is madness. This is a media person with huge social skills thinking they're autistic. That's the problem that concerns all of you here in the room, I'm sure. You're not really interested if a bunch of academic researchers are interested in whether there should be 8 criteria for schizophrenia or 9 criteria or whatever.
Isn't it up to you to get beyond those simple 8 criteria that I've looked up on the internet and convinced myself of my own?
No, well, the problem is we've lost judgment. One of the things that's gone at the moment is the ability for doctors, clinical psychologists, or anyone to exercise judgment of any sort and say, look, just because you meet criteria, you don't have an illness. You know, you've got other problems maybe, but you don't have an illness. I take issue with what Richard has said about people in mental health aren't interested in your story. I think just as anywhere else, in fact, probably more so than in the rest of medicine, that is exactly what we've been interested in. The primary complaint, I bet you, that patients have when they come to Richard, who've got schizophrenia perhaps, is not that my doctor wasn't interested in my story, but they've got me on these drugs which degrade the quality of my life extraordinarily badly. And what does Richard do about that? Nothing. What does Dinesh do about it? Nothing.
Richard, you come back.
It's quite nice that he's making decisions on our behalf.
Yeah, I was going to say, it's nice to be told what I think. So I agree with a lot of what David says, of course. I agree about the way that psychiatric diagnoses have been marketed by drug companies and the fact that people find them. You can find websites where you can diagnose yourself with all manner of conditions these days, and I think that's harmful. I think that leads to a sort of massive misunderstanding of it leads to normal experience being thought of as something wrong with the individual. So there's a lot of what David says that I agree with. But I don't think that sort of really detracts the point that it is, I just think it's true that patients in general don't think that psychiatric services are particularly interested in their life stories. And I think that is because the conceptual system of the psychiatric services is built around diagnosis largely. It's a medical model. It's the idea that if you go to a psychiatrist, I mean, obviously not all psychiatrists are like this, but if you go to a psychiatrist, then you have an illness which is similar, analogous in some way to the kind of thing you have when you have a pain in your gut and you go to a GP.
Well, Dinesh, you've got to defend the profession now. It's been accused of having a narrow range of diagnosis, a lack of judgment, treating people as if they've got an illness.
How much time have we got? I think going back to the point that David was making, there was a very interesting study looking at 1.2 million admissions in Denmark. And they found that 51% of patients had 16 diagnoses. And in their criteria, there were 282, so 200 and something are they needed? I don't know. But that's, a kind of separate debate. But in terms of, I think I take exception to the fact that Richard is saying that, we don't listen to patient stories. Patients get tired of going through the same story over and over again with different people. What we are very bad at is communicating. We may communicate with the patient, but we, quite often don't communicate with others who may be involved. And one of the big challenges I always find is that this whole notion of patient confidentiality. If there are 2 members of the same family being looked after by 2 different teams, there's no communication. And, things are happening in the same family which are affecting 2 individuals, but somehow the system is not allowing us to integrate that or integrate their care or share what's going on. And part of the challenge for us, and I've kind of said it to my colleagues in the Royal College, and I'm going to do the same, is one of the things that we've shied away from in psychiatry is the notion of public mental health. And we haven't stood up and said there are things that mental health is everybody's business, and there are things that we can all do to protect ourselves. Whether we develop schizophrenia or not is a different matter, but we can certainly cope with, life events leading to depression or leading to psychosis, etc. But it's also, I think one of the things that I'm picking up is that we are kind of just focusing on psychiatry is far more than schizophrenia or depression. There's dementia, there is, whole host of psychosexual problems, whole host of anxieties and phobias, and not everything gets treated by drugs. And, and all those experiences are real for people who are suffering.
The implication of listen to your story is that all that's wrong with you is that you have a story that's gone wrong, and if that's the case, you shouldn't be in the mental health system. There should be people listening to you, but you shouldn't be in the mental health system. The kindest thing we can do for you is to say, look, you shouldn't be here. The illness is what, you should have an illness if you're in the mental health system. The problem we've got at the moment, though, is this, and I disagree with Dinesh, but probably more you when you asked him to defend the psychiatric profession. I'm the one that's doing that, saying the illnesses are real and we sort of opened up hospitals first. He's there saying we're 150 years behind medicine. We lead the way in psychiatry, unfortunately, and we're leading the way in this area also. What's happened is that moving out from the core illnesses, the real things like where you've got severe osteoporosis. This is the kind of condition where if you have it, you're at risk of breaking a bone. What the pharmaceutical industry have done extraordinarily well is move osteoporosis out from being the kind of thing that an orthopedic surgeon sees 1 or 2 times a year to the kind of condition that 1/3 of the female population over the age of 60 have. They've done this this isn't a mental health issue, it's across health. They do it with osteoporosis, they do it with lipid levels. I mean, I've got a cholesterol level that pharmaceutical companies have medicalized and said this should be treated with pills. Now, that's the wrong thing to do, but it's not just mental health they're doing it in. And this is the problem with the categories we have at the moment. It's not that the categories are wrong, but it's the way marketing departments are deploying them.
But to pick up on Dinesh's point about a public discussion about mental health, is the danger of that, of opening it up to people like us who don't really know what we're talking about perhaps, is that we all just are given a label and we all feel much happier with a label, and in a sense then the pharma company's work is done for us. We're just achieving a proliferation of conditions, and we can all say, oh yes, I'm a bit like that.
You need to take the debate back from people like us, because the industry are manipulating us extraordinarily well. They're manipulating Richard also, even though he doesn't actually prescribe drugs. If he wants to hear, I can tell him out. But, the public needs to take the debate back from us.
Richard.
Okay, so I want to speak on something which Dinesh said, actually, which is, I think, very important, which I agree with very much, which was the point about the need to think about mental health at a public level, public health level. And again, the reason why that's not happening is that psychiatric problems are largely seen as very individuated. They're seen as things which are wrong with the individual. But I'll be talking about this later on, but if you look at social determinants of mental health, there are numerous social determinants, but they include things like poverty, social inequality, migration, urbanicity, living in urban environments. All these things have been linked to both common and severe psychiatric disorders. Maltreatment of children is another one, which is known to have a massive effect, increasing the risk of psychiatric disorders, however we want to describe them in later life. If we want to do something about mental health in the population, it's those kind of things which we need to be addressing. And all those indicators, nearly all of them are going in the wrong direction. There is more migration than there's ever been. A couple of years ago, the UN announced that for the first time in human history, half the world's population living in cities. Inequality since the 1970s, this is it's a fact, but also has enormous political implications. Inequality has been increasing in the Western world. I'm not sure about child maltreatment. I don't think there's particular evidence that that's getting worse. A lot of these indicators are going in the wrong direction. And we need to, if we want to make the world a happier, more mentally healthy place, we need to get out of the psychiatric clinic and start dealing with these real-world determinants of mental health. We need to change the world, not change people.
That's putting an awful lot of responsibility on you guys, or is that then
I agree with Dinesh that this is everybody's business. Everybody in this room needs to be worried about these things and concerned about things. And next time you vote, you might want to think about these things.
I just don't agree with that at all. All of these things are hugely important, and you in the room are the people to sort this out, not us three up here. Doctors deal with illnesses. That's our restricted area of expertise.
Doctors don't deal with illnesses. Doctors deal with diseases.
Well, okay,
that's the problem.
We can agree on that one, absolutely. But the research Richard quoted to you about the social determinants of mental health comes from an era where there were much fewer mental illnesses, in the sense of much fewer people labeled with an illness and given pills than there are now. When the antidepressants were introduced first, okay, there was roughly only, of the people who are on antidepressants now, there's 1,000 times more people being diagnosed as being depressed now compared with when the pills were introduced first. We haven't had a 1,000-fold increase in the rate of poverty or inequality or things like that. These are all important things. The greatest social determinant of mental health at the moment is the marketing departments of pharmaceutical companies.
Okay, so I've just got to say, actual fact, there's no contradiction between what I've said and what you've said, but I would like to just point out there is a massive amount of epidemiological research which has been published in the last 5 years, and I can say this with some certainty because I've published some of it, which actually shows that social determinants of mental health are here now in society today. They're not things which happened in the past. But you're completely right that if you look at, for example, antidepressant usage in some parts of the world, it's something like a fifth of the population, I think. You might want to correct me on that, but I think it's something like a fifth of the population in any 1 year take antidepressants. And that, by any sense, is crazy. And it is, of course, due to the success of pharmaceutical company marketing departments.
The challenge, I suppose, absolutely social determinants determine, illnesses, both physical and mental. And part of the challenge for all of us, and we've ignored that completely, although David did accuse me of sort of talking about body, but see, one of the major disadvantages of Descartes and Cartesian mind-body dualism has been that somewhere mind is somewhere there and body is somewhere there, and they don't seem to talk to each other. Whereas in lots of cultures and lots of other systems, they're integrated and it's affected by, what you eat, the weather, the climate, your relationships, something you may have done or not. So part of the big challenge for psychiatry is to bring those two bits together, the physical and mental bits, so that you see the patient as a whole rather than this is just a psychiatric disorder and I'm not bothered about what the medication is doing to the rest of your body or whatever else.
Some of you will know that the neurotransmitter dopamine has been implicated in severe types of mental illness, so that's the idea of some overactivity in the dopamine system. But we know from animal studies that animals which are maltreated actually develop a sensitivity of the dopamine system. We know from studies of children who've been sexually abused that if you follow them up into adulthood, put them in a brain scanner, what you find is that their brains are different than children who've had a benign childhood. So a lot of the biological changes which are happening in people who have psychiatric problems are linked to the social world. But it is important to understand those changes. I do some neuroimaging research myself. It's very important to understand those changes because they will help us, in the end, piece together both the pathways which lead to illness, but also devise new therapies to help people.
Okay, so a holistic approach, links to the social world, perhaps not such great links to the social world. Where do we go from here? What's the future of mental health? How could it change? Should it change? What would make it better? We've touched on some of this already. Richard, would you like to go first?
I think David started off by talking about power, and I think power is important. There have been a lot of mental health professionals, people like myself, people like David, people and Dinesh, but there are as a critical psychiatry network in Britain at the moment who are trying to change the mental health system in this country and making it more humane. It isn't a psychologist versus psychiatrist thing. There are people in all, I think, mental health professions who want to see a better, more humane approach to psychiatric care, but it's really difficult. The processes which are, the impediments to change are enormous. The pharmaceutical industry being one, but it's not just that. There's also managerialism in the NHS. The people who have a lot of power but don't realize it are actually the consumers of psychiatric services. They're the people who actually use psychiatric clinics. And often they're very vulnerable people, so they don't realize they have power. But in cases where they are able to say, listen, this is not good enough, we need something different, then they can bring about change. And I think that what is really going to bring about change, improvement in mental health care, is actually going to be an empowered, vocal consumer, mental health consumer movement.
Yeah, I would agree with Richard on that, but it's not just a mental health issue, it's across health. We've moved from a world where if you were on any drug at all, whether it's a lipid-lowering drug or an asthma drug or an antidepressant, and you brought a problem into a doctor like Dinesh or me, or brought it to Richard 20, 30 years ago and said, look, I've just been put on this pill and I've turned blue, we'd hold the pill, and if you stopped being blue, if it cleared up, and maybe if we tried the pill out again and you turned blue again, you and I would be sure that the pill has caused a problem. Trouble is today, we're in a world where you go along to a doctor or a clinical psychologist on any antidepressant or any antipsychotic or whatever, and you say, this has happened to me. The doctor and the clinical psychologist will defer to a bureaucrat in the MHRA, who's in there because they don't like meeting people, who has never used the drug that I might have put you on, okay, who's never treated the condition that I might be treating you for, they may have a background in respiratory medicine and I'm treating you with an antidepressant. And most doctors, 99% of doctors, including presidents of the Royal College of Psychiatrists, will defer to the bureaucrat in the MHRA rather than exercise their own judgment anymore. If you try and get outside that and go to a critical psychiatrist or a clinical psychologist who's in that group, they won't be much more help to you either. So you do need to take power back. You do need to say, look, this has got crazy. They're saying to me, I've turned pink or blue or whatever, and they're saying to me that I can't believe the evidence of my own eyes. That's the problem we've got at the moment, and that's what we need to try and put right. And it can only be put right by you rescuing your doctors and clinical psychologists from the grip of the pharmaceutical industry.
Well, so Dinesh, you need to be rescued. The patients need to take back power. We need to talk more. Where does the future lie, as far as you're concerned?
As far as I'm concerned, I think the future lies in training. I think we need to change the way we train doctors. Mental health needs to be on everybody's agenda. The day any medical student starts medical school, they should start learning about mental illness or impact of physical illnesses on individuals' functioning and mental well-being. We need to bring more sociology and anthropology into training medical students in particular. And the need to, if I had a free hand, I would change the curriculum completely. I'm not going to have it, so I'm going to sort of tinker around at the edges. But equally importantly, I think I agree that we do need advocates. We need advocates for psychiatry in the same way that our patients need us as their advocates. It's a two-way process and two-way relationship.
That was fantastic. Thank you very much to David Healy, Dinesh Bhugra, Richard Bentall.